So this is the case scenario that you are seeing. So as I said, the questions you can expect in the exam, in the Viva, anatomical and physiological changes in pregnancy, you should be thorough. Rheumatic fever and rheumatic heart diseases, the pathophysiology and presentation, clinical features, that you should be able to say all the questions. And third, the mitral stenosis part of it, clinical presentation, the complications, treatment, effects in pregnancy, and anesthetic management. So these are the three subtopics in which you can be questioned. So be prepared for all these three. Now it will be like a question answer, the changes in various systems. So first always start with the cardiovascular system. That is the most important change that you will see in that. And the changes start at the second month or 8 weeks of gestation. And they are all because of the hormonal changes, because of the domination of progesterone. There's a decrease in SVR, and the maintenance of arterial pressure initially by when there is a vasodilatation, you expect a hypotension, but that is compensated by increase in the stroke volume and later in increase in the heart rate. So the cardiac output will increase, and that is how the blood pressure is maintained. And slowly the stroke volume increases because mainly the end diastolic volume and left ventricular muscle mass also increases during pregnancy. So that is the way the stroke volume increase happens. And increase in blood volume starts at 6 to 8 weeks and reaches maximum at 32 weeks. And the overall increase of almost about 2,000 ml, out of which the RBC increase is only about 20%. So because of the there is no corroborative or increase in RBC in parallel to the increase in plasma volume, this is there is a slightly anemic change that is happening, which is called the physiological anemia of pregnancy. The disproportionate increase between plasma volume and the RBC, this causes a apparent decrease in RBC content, which is called the physiological anemia of pregnancy. Now, what is the purpose of all this increase in volume? Why pregnant mother has to accumulate fluid in the body? Soundarya, are you there?
Yes, sir.
So what is the purpose of this increase in blood volume during pregnancy?
Hemodilution, sir.
Hemodilution, one. So what is the advantage of hemodilution?
To compensate for blood loss during delivery.
Compensate for
Blood loss during delivery, sir.
blood loss. But hemodilution, will it compensate for blood loss? This is the reason for hemodilution. What about the placental circulation? Is it
Improves the
autoregulated
placental
or not?
perfusion. Perfusion.
Improves the placental perfusion.
It increases the capillary circulation. This hemodilution, when the viscosity is less, the capillary perfusion will be better compared to a highly viscous blood. So because the placental circulation is not under the control of autoregulation, the lesser the viscosity, more will be the placental blood flow and capillary perfusion there. That is one main reason. Second reason is mother is going to lose about 500 to 1000 ml during labor, delivery, and after removal of the placenta. So that is already compensated by this increase in the blood volume. So even though blood volume increases, what happens to the CET and TCWP? They will remain normal. There will not be any change in that. And all these things happen because of the increase in renin-angiotensin aldosterone system activation, which causes sodium and water retention. And because the heart mass is also increased to increase the stroke volume, the heart displays scapulars and laterally by diaphragm moving up, and ECG may show signs as though there is a cardiac enlargement. And What is supine hypotensive syndrome of pregnancy? What is the pathophysiology there?
It becomes supine, it will leads to decrease the pressure 30 to 50 to 30 m of mercury, sir. And due to compression of
Aorta cable compressions.
Will both be compressed at the same time or later?
first 18 to 20 weeks, and later 32 weeks aorta is compressed, sir.
So what will be the clinical picture if a lady has aorta cable compression?
Sudden hypotension.
When? At which position?
In supine position, sir.
That is the most important thing. That is the term itself is self-explanatory. Whenever a pregnant woman who is more than 20 weeks pregnant lies on her back in supine position, she may suddenly feel dizziness, sweating, nausea, vomiting because of hypotension due to enlarged or pregnant uterus compressing on the venous return, pressing on the iliac veins, causing reduction in the venous return, and which reduces the cardiac output and causes a, once she turns to right or left position, lateral position, this compression is relieved, the patient will feel better. That is why even today, you have any old ladies or grandmas at home, they will always advise the young pregnant women mothers not to lie on their back. Always they will teach them to lie only on their the sides. Okay, so one second, I will just see whether my camera can be switched on. The helping hand has come.
Yes, sir.
It could not be corrected. Anyway, I'll continue. Are you able to see the slides?
Yes, sir.
Yes, sir.
Okay. So the supine hypotensive syndrome is one of the common questions they may ask you. So the iliac veins join to form the IVC at lumbar vertebrae 4 and 5 level. When uterus enlarges, this level IVC compression occurs. When it reaches umbilical levels at 20 weeks, both IVC and aorta will be compressed. So initially it will be purely IVC compression, and only when the gravid uterus reaches the 20-week size, it will start compressing the aorta also. So blood from lower part of body is diverted mostly via the vertebral plexus and azygos vein, and this will lead to reduced venous return and decreased cardiac output, and that is called the supine hypotensive syndrome of pregnancy. And earlier it was called late pregnancy, but that late pregnancy term is now removed because it is happening as early as 20 weeks. It is no more called late pregnancy. It is called the supine hypotensive syndrome of pregnancy only. And peripheral vasodilatation occurs, and epidural vein engorgement gets exaggerated during uterine contractions. And more than 500 ml of blood can be transferred from uterus to maternal circulation during each and every uterine contraction. So if the patient is in labor, every time the mother uterus contracts, it will cause an additional 500 ml of blood to the maternal circulation. And IV inhalation agents and regional anesthesia, they will cause further vasodilatation. So you have to be very watchful in these conditions where it may be worsening the hypotension. So you have to, especially in the supine position, so they may ask you to always we have tried to give a wedge under the right gluteal region. What is the name for that wedge?
Crawford wedge.
Crawford wedge.
Crawford's wedge. Very good. Who is Crawford? An Egyptian or Wonderma?
Position, sir.
Okay. Are you able to see my face now?
Yes, sir.
Yes, sir.
Okay.
Yes,
Right.
sir.
Thanks. My grandson has done something. He added an extra camera and made me see. Thank you. So this is the additional. So you have to be always giving this. Supposed to give this Crawford weight, and Crawford was one of the pioneer obstetric anesthesiologists. He's not a physician. So he has written a book on obstetric anesthesia. Full volume is there, and he was the one who designed this. How many degrees? Sometimes the examiners ask you how much of tilt you should give.
15 degrees, sir. If it
15
is
to 30
body
degrees.
hydropnea, 30 degree.
Yeah.
Pregnant.
So it should be 20 degrees from the right side gluteal region, so that the weight of the gravid uterus is taken away from the IVC, so that venous return will be fully maintained. Very good. What are the hematological changes that can happen? It will be, mother can be in a state of hypercoagulability because she doesn't. She should not suffer from postpartum hemorrhage. Nature makes it so that she will be having a hypercoagulable state. All clotting factors except factor 11 and 13 are increased, and decrease in maternal anticoagulant protein C and S, and platelet production is also increased, but count decreased due to dilatation. So dilution because of the plasma volume increase, and WBC count may be high. So if a mother's count is more than 10,000, don't think that she is having any infection. This is one of the common things that can happen in a pregnant woman. Changes in respiratory system are very important for us. Both oxygen and CO2 production are increased. So minute ventilation may be mainly increased by increase in tidal volume, later only by increase in respiratory rate. So just like the CVS producing increase in stroke volume and then adding up to that with the heart rate, here the tidal volume first increases, then the respiratory rate increases. And this only helps to wash out the carbon dioxide which is produced in excess because of the increased metabolism. And there is also a small reduction in PaCO2. Why? Why the mother is slightly alkalotic? This is one of the common questions the examiners may ask you. What is the advantage of the maternal blood having a lower PaCO2 compared to normal and non-pregnant women? What is the purpose?
To compensate for fetal acidosis.
Not fetal acidosis, to remove the CO2 from the fetus. Because there is a fetal production of carbon dioxide also. Imagine a situation where the mother PaCO2 is 40 millimeters and the fetal PaCO2 is also 40 millimeters. Then can the gas transfer occur?
No, sir.
Gases always get transferred according to the concentration gradient. So from a higher area, it will have to come to a concentration which is lower. So only if the mother's PaCO2 is 35 and fetal PaCO2 is 40, then carbon dioxide can get transferred from the fetus to the mother. Otherwise, the fetus will be accumulating all the CO2 because it cannot be transferred to the maternal circulation. And that is the nature's beauty of the way to eliminate the carbon dioxide from the fetus. Maternal PaCO2 goes down. Another reason for that is the production is also increased in the mother, so that also has to be removed. So for these two reasons only, the maternal PaCO2 is always on the slightly lower side compared to a non-pregnant woman. And swelling of nasopharyngeal and oropharyngeal tissues also occur because of capillary engorgement. So in case she needs any nasal intubation, we have to be very careful that it can cause severe bleeding in the mother because of this. And CNS, especially with the vertebral space, the residual epidural space reduces the epidural space because of the engorgement of the veins in the epidural space as well as the subarachnoid. And there is a widening of pelvis which causes the head down tilt of the pregnant woman. So if you earlier we were giving spinal for operative delivery in pregnant women in the lateral position, and if you do not support the shoulders with a pillow, if you just keep the support only for the head and put the patient in lateral position, there will be a downward tilt. Even if the mother lies in the full lateral position, the vertebral column will be having a slight downward tilt because of the widening of the pelvis that is happening. And to avoid this, so that the spread of the local anesthetic will be very much higher even if you give a normal volume. So if you want to prevent that, you have to give a support not only to the head and neck, but also up to the shoulder, so that the head and neck and shoulder will be slightly elevated to straighten the vertebral column so that the higher spread does not happen. And that any name for that particular
Oxford
support?
position, sir.
It is called the Oxford position. Very good. So, and the nerves are all very sensitive to local anesthetics in pregnant women. So lesser concentration also will be able to achieve the same amount of block compared to a non-pregnant woman. And if you are using inhalation agents, the MAC value is very much decreased. So pregnant women require a lesser concentration to achieve the same depth of anesthesia compared to a non-pregnant woman. So the CNS, don't think it is all related to the cerebral, it is the related spinal and peripheral nerves and the volatile anesthetic agent. And uterus contraction will be impeded by the inhalation agent. So if you use more than the MAC value or increased concentration, ultimately it may cause delay in the contraction of the uterus after the delivery of the fetus and the placenta, and that may be one of the reasons for the postpartum hemorrhage also. So it is better to use the minimal inhalation agent concentration. What is the MAC that is used in pregnant women called?
Minimum less than 1 MAC.
So many names for MAC. MAC induction, MAC awake, MAC bar. Is there any name for the MAC that we use in a pregnant woman?
MAC bar, sir.
MAC bar is used in all cases to prevent any surge in the sympathetic stimulation. Whereas here we use it mainly for what purpose?
Uterus.
We don't want to cause any delay in the contraction of the uterus, but at the same time, we should not produce one complication by totally avoiding inhalation agent. What is that complication?
PPH should be restricted.
Is the awareness under general anesthesia, which is one of the commonest complication which can end up in a legal suit or litigation. Okay? Earlier, they were totally avoiding inhalation agents in the mother when they were providing GA for operative delivery. Now they were using very they were totally avoiding inhalation agents at all from induction to fetal delivery time. So at that time, if there was some delay in delivering the fetus, the induction agent effect would have gone, and mother would have perceived the pain or heard the conversations that are going on, which was identified as awareness and accidental awareness under general anesthesia. Can you tell me who first identified this and published this?
Michael.
Who was the anesthetist who identified that there is a complication called awareness under general anesthesia in pregnancy when you administer GA for delivery, operative delivery in pregnant women? There's one person called Michael Tunstall. Michael, Tunstall. Michael Tunstall was an anesthetist from a place called Aberdeen in UK, and he was mainly practicing obstetric anesthesia, and he was the person who coined this or found out this problem of awareness under anesthesia. So we use inhalation agents mainly to prevent this awareness. This MAC is called MAC amnesia. Okay? So the MAC that is used in pregnant ladies for cesarean section under GA is called MAC amnesia stent. And the changes in spinal, why changes in spine ought to be known to all the anesthetists? What are the changes that happened in the spinal column?
The T4 to T5, sorry, the toughest line is going to cephalate, sir, and a loss of, the become.
What happens to the curvatures of the spine? The lordosis,
More lordosis, sir. More lordosis, sir.
So, if you have more lordosis occurs, what will happen to the spinous process?
Crowding, sir. Crowding.
They become close to each other or separate and go away from each
close
other?
to each other, sir. So it will lead
So
to
crowding
reduce
of
the
spinous process will occur. Okay? Increase in lumbar lordosis leading to crowding the lumbar spinous processes. So the gap, interspinous gap will be very much restricted. So many a times when you try to go between the interspinous space, you may be hitting the bone again and again. So it is better to go by the, instead of midline approach, better to go by the paramedian approach, a little away from the midline, where you will have a better opening compared to the interspinous space level in pregnant women. That is one of the important changes that you should know. And the second is softening of the ligaments of the vertebral column. And that happens because there is a hormone called relaxin which is produced by the placenta. So what is the disadvantage of the softening of the ligaments as an anesthesiologist?
we couldn't get the
when you do the epidural, loss of resistance will not be that much felt or easily identified like in a non-pregnant or other patients. And what are the changes that happen in the GIT?
increased risk of aspiration, sir, and the GRT.
Right.
Due to the lower esophageal sphincter tone relaxed, sir.
Very good. So upward displacement of the stomach, increase in intragastric pressure, delay in gastric emptying, and all these things lead to always the chance of full stomach in a patient. Even if they have not eaten for long, there is all pregnant women are to be considered as patient in full stomach whenever they come for any anesthesia or any intervention. What are the changes in the hepatic system? Enzymes AST, ALT, and bilirubin are all decreased because of the dilution, and only alkaline phosphatase is increased because that is produced by placenta also. And the plasma cholinesterase activity is decreased from the 10th week of gestation. So if you use choline for rapid sequence induction, it is always preferable to wait for the effect to wear off and spontaneous to return before you give any non-depolarizer in a pregnant woman. Otherwise, you may miss a cholinepnea and administer a non-depolarizer, which will make the patient remain paralyzed for a very long time. So this point is very important for those who use choline for rapid sequence induction in pregnancy when they give GA. Better wait for the effect of the choline to wear off and make sure that there is a spontaneous effect coming, and then administer non-depolarizer if you want to continue with the control ventilation. Now renal, what are the changes in the renal? Increase in renal blood flow. So GFR will increase from second trimester, and that is the reason why there is more urine production, and the frequency of urination will increase in pregnant women, and there will be a decrease in urea and creatinine by about 40%, and increase in aldosterone activity, which will cause sodium and water retention. And that may be the reason for some of the physiological edema that you see in the lower limb of the pregnant women because of this. The endocrine reason, there will be increase in the size of the thyroid gland, even in a normal patient. And because the human chorionic gonadotropin It resembles the TSH, alpha TSH. So patients who are sensitive or having a hyperthyroid state will have more problem or exaggeration. So they may require higher doses to control their hyperthyroid activity. And diabetic patients, they will become insulin resistance will be there because of the placental lactogen production. So one of the reasons for gestational hypertension is increased production of this lactogen and making the patient diabetic also. And these are all the general principles for anesthesia for LSES. We have to do a thorough pre-anesthetic evaluation, detailed maternal and history and examination of the vital, look for significant operating anesthetic risk. And in patients with mitral stenosis, we must ask for new onset breathlessness because majority of the mitral stenosis mothers, they may not be having any symptoms before they become pregnant. So mild mitral stenosis will be not detected before surgery or before pregnancy, and that will be exhibiting only after the mother becomes pregnant. And that is the reason why I asked you about the changes in CVS because of increase in the volume as well as the changes in the peripheral vasculature. The mother will become symptomatic only when they become pregnant. So any new onset breathlessness or exertion should be sought for during the especially third trimester. It will be very, very prominent. And this ample mnemonic is useful for any situation where you can ask quickly as a pre-anesthetic evaluation the 5 questions. If the patient has had any allergy for any medicines or food, and what are the medications the patient has been taking, any previous anesthetic exposure and any untoward incident with that, last intake of solid or liquid food, and events leading to the need for surgery. This mnemonic was coined by one Dr. Christopher Grande in trauma anesthesia, where you just ask these 5 questions. You can most of the time pick out any problems in the patient and adjust your anesthesia according to that. So this acronym has now been used for any situation where you have a very short time to make a detailed evaluation. You can use this and elicit these important points. And always examine the back of the patient to assess the ease of spinal anesthesia wherever possible. And comorbidities like any spinal deformity or a previous spinal surgery, obesity, and any coagulation abnormality should be noted in pregnant women. And contraindication to spinal anesthesia should be identified, and patients should be evaluated always for an alternate plan. Or even in cases where you plan for spinal anesthesia, sometimes there may be a situation where you may not succeed in giving a spinal anesthesia. And in that situation, you have to go for general anesthesia. So always look at any patient, whoever you are planning for regional, always, whether it is not only for obstetric or for any other surgery, whenever you plan for regional, always make an assessment of the airway and the mouth opening, the neck position, everything. In case you want to convert it to a GA with endotracheal intubation, you should be prepared. So always do that as a routine in all patients. Now, special airway assessment is very important in the mother because the reason why the European community or European Society of Anesthesiology advocated that spinal anesthesia should be the choice for operative delivery in pregnant women is because of the airway complications that resulted in a lot of maternal morbidity and mortality in the European countries. So failed intubation and hypoxemia causing morbidity and mortality was very, very high as found out by the national audit on the maternal mortality. Confidential inquiry report showed that GA caused more problem than regional, and that is the reason why the European Society said that for all categories of cesarean, spinal should be the first choice. What are the categories of cesarean section?
Emergency and urgent.
Huh?
Emergency, urgency.
How many categories are there?
4 categories, sir.
What
Elective.
is first category 1? What is the category 1?
Category 1 is emergent, sir.
Emergent mean, what do you mean by exactly? How is it described in this classification? Is it just says emergency, or is there a time frame that is
It is
fixed
like
for that? Once you say category 1, it indicates that there is a distress in both mother as well as in the fetus. And once the patient has been declared as a category 1 cesarean section, the baby should be delivered within the next 30 minutes, after declaring that he is a category 1 cesarean. That is the entire definition of category 1. Okay.
Yes.
So in European countries, they use this classification only, unlike our physicians who still follow emergency caesar and elective caesar. The 4 categories are: category 1 is a danger to the or threat to the life of both mother and fetus, and the baby should be ideally delivered within 30 minutes after declaring that she is a category 1 cesarean. And this is the only category where they advocate that GA can be administered because spinal may take a little longer time. And there also they have modified that class of administering GA by adding a new terminology there.
Rapid
where
spinal.
you can still admit, it is called rapid spinal.
Rapid spinal.
Okay? Rapid sequence spinal, where you don't scrub fully, you just wear a glove, and the scrub nurse herself will paint the back of the mother, and she will take the needle, load the drug, keep everything ready, and just to come and palpate the landmarks and give the spinal, so that the time needed for giving the spinal is very much reduced. That is called the rapid sequence spinal. Just like your rapid sequence intubation, there is a terminology which has been introduced in the for category 1 cesarean section, which is called rapid sequence spinal anesthesia. Whereas category 2 is a condition where the fetus is in distress, but mother is safe, and you can take a little more time. And, category 3 is little more relaxed thing, and it is better to deliver as soon as possible. There is no time frame for that. And category 4 is only what is called the elective delivery, elective cesarean section. So in all these cases, there may be need to identify the airway properly. So we go for the regular Malambati, proceeding mandible, protruding maxillary incisors, and short neck circumference more than 40. All these things are common things which will indicate a anticipated difficult airway. And you have to do this common investigations like TBC, blood sugar, etc. And order for blood type and screen and cross-match blood to transfuse in case there is a necessity. And informed consent for anesthesia and surgery should be always obtained in any case. And preoperative preparation, fasting, wherever possible, will be good. But in emergency like category 1 cesarean, there is no time. So you have to take all the precautions to prevent aspiration by providing all the drugs like intravenous pantoprazole, metoclopramide to hasten the gastric contractions, and try to prevent aspiration by proper head positioning and Selix maneuver, rapid sequence induction and intubation. All these things have to be followed. And for elective, you can allow clear liquids such as water, fruit juice without pulp, and tea without milk. This question is repeatedly asked nowadays. What are the fluids that you will allow, and what is the quantity that you will allow? So the clear fluids contain water, fruit juices without pulp, tea without milk. So that's the black tea. So how much quantity can you allow? Any idea?
400. 400
100
ml.
400.
100 to 150
1
ml.
ml per kg is the ideal thing. Okay, so that is what is the maximum you can have. It is just to keep the throat and the mouth moist. It is not given for any reason other than that, just psychological satisfaction. And they have found that the incidence of nausea and vomiting is less when there is small amount of liquid in the stomach rather than being totally empty, where the acid production will be much more higher, and that will cause the reason for the nausea and vomiting. That is the reason why they have started allowing this sort of clear fluids. And the maximum that you can give, for example, if the patient is 60 kg in weight, you can allow them to drink up to 60 ml in divided doses. Okay, so that is the safe limit. Up to 2 hours you can allow that. And prophylaxis of aspiration of gastric contents is very important. And they convert the acid secretions. You give an alkaline solution called sodium citrate, 30 ml of 0.3 orally, and metoclopramide prokinetic you can give. Ranitidine was given earlier, now it has been stopped, and we are giving more of pantoprazole intravenously. And because we should have a large bore IV cannula, and left lateral displacement is very, very important to internal hypertension. And antibiotic prophylaxis should be administered, and all the surgical safety lists should be checked. And intraoperative monitoring, the regular monitoring what we use is more than enough. And if you are going to administer GA, you should better have the end-tidal assessment of all the volatile anesthetic agent and oxygen and carbon dioxide to be monitored. And the method of anesthesia commonly preferred for regular patients is single shot spinal, because that is more convenient, simple, easy to perform, and quite effective. But in mitral stenosis, this is not the case, and this is what I am describing for a regular cesarean section. And SA also has higher maternal satisfaction because nowadays the physicians allow the baby to be given to the mother, and skin to skin contact will be there. So mother can immediately handle the baby, and she will be very thrilled and satisfied to see her newborn. And that is considered a very great advantage in the psychological happiness of both the mother, and the child also feels the warmth of the mother, and the outcome in the fetus is also supposed to be good. These are all the details of how you administer the spinal anesthesia. So nowadays we go for very small gauge needles like 25, 26 or 27 with the idea to prevent the post-dural puncture headache. That is the main reason for that. Very fine needles are used, and the drugs that are used are hyperbaric bupivacaine, and lidocaine is not available, and the ropivacaine is also being used in some centers. Maybe ropivacaine can be used, and the level of block required is supposed to be T5 for touch. But there is always a question: why do you require such a high block? What is the nerve supply to the uterus?
Parasympathetic S1 to S1, S2, S3, sir. Sympathetic to T1 to T4, sir.
Sympathetic for the body and the fundus and body and the upper segment of the uterus is only from T10 to L2, T10, T11, T12, L1, L2. So why do you require a block up to T4 or T5?
While handling in the uterus, externalization of the uterus, it will leads to
it is
pains.
to avoid or prevent the peritoneal stretching that can happen when they try to push the baby out, but through the small incision they make in the lower segment of the uterus. Okay? So the compression or exteriorization of the uterus will cause a stretching of the peritoneal covering on the top of the uterus. And to prevent that only, you require a block up to T4 or T5. Otherwise, there will be a short period of discomfort to the mother when the physician gives the fundal pressure to deliver the baby. Okay? Supposing you want to avoid that without reaching such a high block, what are the methods that you can adopt? Where you want to give a small dose and achieve only a block up to T12 or T10 rather, and by giving a small dose, can you avoid that fundal pressure and stretching of the peritoneal discomfort?
We can give further analgesia by using oxygen and nitrous oxide, sir.
Anything you can add to the local anesthetic without raising
fentanyl,
the
10 to 15 mites of fentanyl, sir. Opiates, sir.
Fentanyl can be added. Okay, you can add 25 micrograms of fentanyl and reduce the quantity of or volume of the local anesthetic. That will achieve a block up to T10, which will not cause a sudden hypotension, and the discomfort of this fundal pressure can be blocked by the fentanyl that is going to act on that. In healthy normal women, we can give 10 to 15 milligrams of IV ketamine at the time of fundal puncture and delivery, which will also have an effect on the effectively block this discomfort. Okay? So these are all the various techniques of neuraxial blockade like epidural, coupled spinal, continuous spinal, all these things. But all obstetric OT should have a difficult airway card in case you want to convert or in case you plan to have a GA straightforward. All OT should have this difficult airway card so that you can manage it. And general anesthesia for cesarean delivery is indicated in emergent delivery or contraindications to neuraxial anesthesia, including maternal refusal or coagulopathy, sepsis, severe hypovolemia, or intraoperative convulsion. The patient is experiencing pain. All this will result in the need for giving GA. So always pre-oxygenate the patient and keep the position 20 to 30 degree left field, and then rapid induction with pipetone or propofol in a very titrated slow fashion can be given, and succinyl choline 1 to 1.5 milligram or rapronine can be given, and intubation done with a comparatively smaller size centrifugal tube. Don't use the conventional size tube of 7 or 7.5 if you use for a normal non-pregnant woman, because there will be mucosal edema. During intubation, it may be difficult to intubate, as well as after extubation, there may be a laryngeal edema which may cause an obstruction. So always better to use a smaller size tube. And if the patient is having MS, what are all the goals that you have to maintain in the management? That is remembered by the mnemonic PACRRI. The P stands for preload, A stands for afterload, C for contractility, R for rate, R for rhythm, and I for ischemia. So the preload should be just adequate. Neither overfill the patient or underfill the patient. So adequate diastolic filling, and always aim at a slower heart rate. Avoid tachycardia at any expense, and maintain sinus rhythm. Aggressively treat if already patient has been in AFR, likely to go in for AF, and judicious fluid therapy. And of course, ischemia is not very common in this age group, but always any cardiac patient, you must try to avoid ischemia by diastolic hypotension or tachycardia. And to maintain the normal SPR in a pregnant woman, phenylephrine will be a drug of choice over ephedrine. Why?
Is the reflex bradycardia, sir. So we should avoid tachycardia.
Venoconstrictor, so it will bring back the blood pressure without increasing the heart rate. Whereas ephedrine has a central and a peripheral effect. It will cause vasoconstriction as well as increase in the heart rate. So that is not suitable for patients with mitral stenosis. So any hypotension requiring treatment is better treated with phenylephrine in patients with mitral stenosis. and also prevent increase in pain, hypercarbia, acidosis, because that will increase the pulmonary vascular resistance and pulmonary hypertension will happen. Invasive monitors are needed only in cases of severe and critical meteorology. And the post-op, they should be managed in the head of high dependency units with oxygen supplementation, and the whatever goals that we kept for intraoperative management should continue in the post-op also, at least for 48 to 72 hours. And patients who are already on diuretic, you can restart them in the post-op, as well as drugs which are given for atrial fibrillation also should be continued. And the patients who are taking warfarin, if they have already experienced atrial fibrillation, to prevent thrombus formation, if they have been given warfarin, that can be started after 24 hours. Until then, you can go in for heparin. Why heparin is preferred to warfarin?
There is no need of
Warfarin
monitoring, sir.
encephalopathy.
And unfractionated heparin. Unfractionated heparin is short acting.
Why unfractionated heparin is always better than any other
It is short acting.
It's a short duration of action. Half-life is only 4 hours, and you can always titrate. And second thing, you can reverse it with protamine. In case there is an excessive bleeding, you have an immediate reversal agent is also available. Whereas warfarin onset itself takes about 48 hours to 72 hours, and even if you discontinue that, it again takes another 3 days to come out of the effect of that. Why it is called warfarin?
It is a cube.
Huh?
It is a
an
cube.
acronym for anything? Can you find out why it is called warfarin? There is an acronym for this drug name. It was found out by some university in the USA, and they named it as warfarin. Try to find out the answer, otherwise I'll tell you in the last. And potassium to be monitored in case they are taking diuretics and digoxin. And the merits and demerits of inhalation agents, they are especially important for preventing awareness, as we saw earlier. But increased dosage will definitely cause reduction in the contractility of the uterus and maybe causing a hemorrhage, postpartum hemorrhage. The methods of securing the airway. Conventionally, we use only endotracheal tube of smaller size, but in case of difficulty, they have anesthetized patients with supraglottic airway devices also, of which LMA ProSeal or the third generation LMAs are all very successfully used because they have a gastric drain, through which any regurgitation can be removed. And the accidental awareness under GA, I told you about that. It is 30 times more common for all anesthetics, especially in pregnant women. And it occurs between the induction and the start of the surgery. That is the delivery of the fetus, during which time most of the anesthetists prefer not to give any inhalation agent or opioid because of the fear of depression of the fetus. The Apgar score in the fetus will be very much high, and so very much low. So we don't want the fetus to be depressed. So that is the reason why patients may have this problem of awareness. And administering neuromuscular blockers without confirming loss of consciousness, obesity, and omission of opioids are all reasons for accidental awareness. And prolonged induction to intubation time as well as induction to delivery time are the other two reasons for that. And adequate alveolar concentration of volatile anesthetic agent will definitely prevent this particular without being happening. And extubation after cesarean delivery, there is a risk of regurgitation and vomiting during extubation if you are giving anesthesia, general anesthesia. So it's always better to have a head down tilt with the head turned to the lateral side, and make sure the patient is fully awake and all reflexes are there, and then try to extubate the patient. And post-op analgesia for cesarean, multimodal analgesia is used. Acetaminophen and NSAIDs are given. Nowadays, routinely transverse abdominal spleen block is given. Bilateral block has to be given. But this block, is it effective for visceral pain?
No, sir. It is a sensory block, sir.
It is a mainly sensory somatic block, so it may not give adequate visceral pain relief. So for that, you may have to give IV opioid. And infiltration of the skin incision is also being performed routinely by most surgeons nowadays, so that the incision pain will be less. And the uterotonic drugs usage is very, very important in mitral stenosis also. So the first line of drugs that you can use are oxytocin and carbotocin, and the other drugs, ergometrin, is nowadays not at all used because of the severe hypertension and nausea vomiting it can produce. Misoprostol is a second line drug. Carboprost, all these prostaglandin analogs are being used. So these are only second line drugs, and these two are the first line of drugs, and we have to use them judiciously to achieve required contraction of the uterus. The causes of MS, coming to the discussion of MS, the rheumatic heart disease is the most commonest cause. Other things are SLE, carcinoid, left atrial myxoma, etc. And the features of rheumatic fever, as I told you, is an immunologically mediated inflammatory disorder. It occurs as a cyclic to group A streptococcal pharyngeal infection, and it affects various systems in the body. It is not only the heart which is affected, it is the joints, brain, cutaneous and cutaneous tissue. And acute rheumatic fever remains a preventable cause for cardiac disease. And the age group children affected will be between 6 and 15 years. The family history of rheumatic fever and lower socioeconomic status are additional factors. And this group A streptococcus, they produce antibodies against streptococci. These antibodies cross-react with human tissues because of the antigenic similarity between the streptococcal component and human connective tissue component, which is called the molecular mimicry. And immunologically mediated inflammation and damage happen, which results in affections of the heart, joint, and other tissues. Clinical features. The mnemonic to remember five major and five minor criteria according to Duckett-Jones. And the major criteria are arthritis, carditis, chorea, erythema marginatum, and subcutaneous nodule, which you can remember as phases. And phases mnemonic: fever, arthralgia, increase in CRP, increase in PR interval in the EKG, and sedimentation rate increase. And this is the picture of the erythema marginatum, and this is the subcutaneous nodules. In case you happen to get a case of that, nowadays it is almost become non-existent because of the good socioeconomic conditions, and incidence of rheumatic fever has come down very much compared to yesteryears. The treatment of acute rheumatic fever, that also can be asked by the examiners. So bed rest, supportive therapy, if there is a heart failure or other complication, eradication of organisms. Benzocaine penicillin is supposed to be the drug of choice, and anti-inflammatory agents that can be given are NSAIDs mostly. Aspirin is the drug which is preferred, 100 mg per kg per day. You can steroids, corticosteroid 1 to 2 mg per kg. Preventive measures are continuing benzoyl penicillin, IM every 4 weeks, or penicillin 250. In case they are allergic to penicillin, erythromycin is the alternate drug. And the rheumatic prophylaxis should be given at least up to 21 years of age. Then only the patient will become free from the rheumatic activity. Normal features of anatomy of the mitral valve can be sometimes they can ask you. It is the largest valve in the heart, 4 square centimeters, and it has a diastolic flow of 100 to 200, 150 to 200 ml, and the gradient between the atrium and the ventricle is about normally less than 2 millimeters, very minimal gradient. And the classification of mitral stenosis is made on the following features into mild, moderate, and severe. The mean pressure gradient, if it is less than 5, it is called 5. 5 to 10 is moderate. More than 10 millimeters is considered very severe. And it will increase the pulmonary artery systolic pressure also in these cases. Less than 30 is mild, 30 to 50 is moderate, and more than 50 is severe. And valve area. So these three criteria should be taken into account to consider which category it belongs to. So from 4 to 6 centimeters, it may reduce to 1.5. Then it is called mild. 1 to 1.5 it is moderate. Less than 1 is called severe. Less than 0.07 is called
Critical.
critical. Yes, very good. So describe the pathophysiology of mitral stenosis. So normal valve area is so big, orifice reduces. So blood flow from left atrium to left ventricle is elevated by the pressure gradient. So the left atrium has to increase the pressure to push the blood through the narrow valve. So what happens? There is a back pressure effect going on to the first pulmonary vein, then it will get transmitted to the pulmonary capillary circulation, then go on to affect the pulmonary artery. So pulmonary hypertension will develop, and because of the stretching of the left atrium, because of the constant under emptying, it will lead to atrial fibrillation also, and tachycardia because of the atrial fibrillation will worsen the pulmonary congestion, and cardiac output will slowly decrease. So patients may have very low blood pressure, and the apical impulse will be very soft and tapping in nature. And the clinical features become mainly because of the decreased cardiac output. The early patients will have fatigability and syncope. Then increased left atrial pressure can cause pulmonary congestion, dyspnea, orthopnea. And paroxysmal nocturnal dyspnea is a very important condition. Even if it has occurred once, it is considered that the heart is a decompensated one. So you can ask for a history of sudden waking up in the night with the breathlessness. And physical findings, you will say you will have malar mitral phases, which is not common in our people because of the dark skin. It is more prevalent in the white skin people. And if the pressure has gone on to the right side by the back pressure effect, then you will have raised JVP, ascites-pedal edema, which indicates that right side heart is also affected. But as long as the pulmonary pressures are okay and pulmonary hypertension has not become severe, you will not develop all these things. That means it will be a purely left-sided dysfunction. And tapping apical impulse, sometimes atrial fibrillation, all these things will be there. Auscultatory findings, you will have a loud S1 and slightly delayed. S2 may be very split in a very close fashion, and P2 will be accentuated, and the murmur that you hear will be there will be opening snap as long as the valve is pliable, and you will have a low pitch rumbling mid-diastolic murmur following the opening snap, which will be best heard at the apex of the location of the apex in the left lateral position with the bell of the stethoscope at the end of expiration. So this description is sometimes expected from the examiners for you to do clearly say as you have learned it in your undergraduate days. Now, what is Carvalho sign? When does it happen? One, Sundarya, are you there?
No, sir.
Okay. The Carvalho sign is a pan-systolic murmur that can be heard along the left sternal border, which indicates a severe pulmonary hypertension. So there are many methods to find out the complications of mitral stenosis in a clinical fashion itself in those days. before the echocardiography and all those things came. So at the time they found that it can be a pansystolic murmur when you auscultate over the left edge of the sternum, and that indicates pulmonary hypertension. And it is louder during inspiration and diminishes in post-expiration. This is the characteristic of this particular systolic murmur. And there is another murmur called Graham-Steele's murmur. When does it happen?
It is high-pitched diastolic murmur in pulmonary regurgitation.
Regurgitation, very good. So it's a high-pitched diastolic decrescendo murmur, again along the left sternal border due to pulmonary regurgitation. So pulmonary hypertension produces Carvalho sign, which is again a pansystolic murmur, whereas a diastolic murmur occurring at the left sternal border is called the Graham-Steele murmur, which occurs because of the pulmonary regurgitation. The complications of mitral stenosis, acute left heart failure, pulmonary hypertension, right ventricle failure, all these things all of you know. And this Ortner syndrome, which is a compression of the retrolaryngeal nerve on the left side because of the left atrial enlargement, and the jaundice and cardiac cirrhosis in long-standing right heart failure because of the congestion in the hepatic sinusoids and produce that. And the features of clinical features of pulmonary hypertension: patient may have palpitation. When you examine, there may be a corresponding heave, palpable S2. When you keep your palm on the pulmonary area on the left sternal border, the second intercostal space, you may find the palpable noise of the pulmonary valve closure. So that is palpable S2. And auscultation, you have a ejection systolic murmur over the pulmonary area, and the systolic murmur which increases on inspiration heard along the left border, which is a Carvalho sign, and Graham-Steele murmur if there is a regurgitation. So these are all the clinical features of pulmonary hypertension, and patient may complain of breathlessness all the time. And the X-ray findings, that is a common question they will ask you: straightening of the left border, elevation of the left main stem bronchus, and double density of an enlarged atrium, calcification, evidence of pulmonary edema, etc. And upper lobe veins dilated, left bronchus will be horizontal. And EKG changes, this is commonly given in the examination for you to identify. So you may have a P pulmonale, which is a bifid notched P wave. And if there is atrial fibrillation, you find the fibrillatory wave. There is no definitive P wave, and the rate will be irregularly irregular. So that is how we identify the ECG finding. Echo findings, mainly for finding out the size of the valve, the pressure gradient, the calcification. These are all the findings that you will have to look for. And sometimes they may ask you to describe the anatomy of the mitral apparatus. So this is the only valve with two leaflets. All the other valves are tricuspid valves, whereas this is the bicuspid valve. So it has an anterior leaflet and a posterior leaflet, which is attached to an annulus. And there are papillary muscles which get attached to the chorda tendina, which get attached to the papillary muscles, which try to pull the valve to open towards the ventricular structure. So this is the importance of, and when these two leaflets meet, that point is called the commissure. So any damage will start at that point and start traveling towards the annular region. And the Wilkinson score is mainly to find out the structure of the leaflets, so that whether the patient can be taken up for balloon valvuloplasty or not. And that is the one which gives the decide the intervention needed to relieve the stenosis, whether it can be conservatively treated with valvuloplasty, or whether it has to be commissurotomy, or whether it has to be mitral valve repair. All the treatment is decided on this score. And they enumerate the causes of AF Other than mitral stenosis, you have so many reasons where patient can develop AF, and the mnemonic to remember is arrhythmic. So consumption of alcohol or presence of ASD, rheumatic fever, ischemic heart disease, thyrotoxicosis, hypertension and hemocentrosis, mitral valve disease, infection, cardiomyopathy, chronic lung infection. So there were so many causes for AF. And the pattern, paroxysmal, persistent, long-standing, persistent, and permanent. These are all the categories depending upon the duration and how they resolve, or whether they resolve automatically or whether they require any intervention. That is the reason for classifying the pattern. And the symptoms, patient may be totally asymptomatic, or they may complain of palpitation, dyspnea, chest pain, dizziness, and syncope. And because of the decreased cardiac output, there will be increased ventricular rate. Loss of atrial contraction will be there. And neurologically, sometimes in older people, this atrial fibrillation may result in transient ischemic attack or even stroke may happen, and systemic embolization can happen. And the consequences of AF are main problem is thromboembolism because of the stasis of blood in the left atrial appendage. That is the location where the thrombus formation will happen. And the quality of life may be decreased in persistent atrial fibrillation, and there will be impaired hemodynamics. So these are all things. That is why sometimes atrial fibrillation will warrant continuous therapy. And the management, three pillars are rate control, rhythm control, and prevention of thrombus formation. These are the three important pillars. And this is the algorithm to get the rate control or rhythm control. First, look into hemodynamic instability. If it is present, better to go for electrical cardioversion first. This is the answer expected out of you. When will you do electrical conversion? Is when the patient is hemodynamically unstable with an atrial fibrillation. The first treatment of choice is electrical conversion. On the contrary, the patient is hemodynamically stable with a known LV systolic dysfunction or clinical heart failure. If it is present, yes, then the drug of choice is amiodarone. On the contrary, there is no systolic dysfunction or no heart failure, beta blocker will be, or calcium channel blocker will be the choice. And if both of them are not optimal to control, then digoxin will be the drug of choice. So this is the algorithm that we have to follow for treatment for rate control. Role of anticoagulation, warfarin is the drug of choice for long-term anticoagulation, and heparin can be used for short-term effects before if there is a acute chance. So any atrial fibrillation persisting more than 24 hours, it is better to start the anticoagulation. And MS, how is it treated according to the severity? If it is grade 1 mild, diuretics for congestion symptoms, prophylactic against rheumatic fever, and if AF is present, anticoagulation and drugs to control the rate. If grade 2, so for treatment it is again divided into grade 1, grade 2, grade 3, grade 4, and grade 4 will be usually surgical repair. And grade 3 also surgical repair because pulmonary hypertension is also very severe. The to grade 2 you can salvage with drugs plus commissurotomy or balloon valvuloplasty. Only when it goes to grade 3 and grade 4, it has to be mainly surgical repair. Percutaneous balloon valvuloplasty indications are progressive deterioration in despite medical treatment, and if the recurring complications and asymptomatic patient with a single attack of thrombosis, they are all the candidates who require. And if the valve size is less than 1 square centimeter, we have to go for balloon valvotomy. And surgical conditions indicated in if both MS and MR are present, it should be MR. MS with left atrial thrombus, heavy valvular calcification, and patient with extremely tight stenosis or still rheumatic arthritis is going on, then it is better to go for surgical valve replacement itself. And coming to mitral stenosis and pregnancy, these are all the changes I told you. There will be increase in heart rate, which is deleterious, increase in blood volume, which is again deleterious. So these are all the things that we have to take into consideration. We take consideration for this thing. And the pressure volume loop will be shifted towards the left in these patients, and that will be causing this decreased cardiac output. And anticoagulation, all those things we have already talked. Heparin, and first trimester, when the organogenesis is going on, warfarin should not be used. At the time, it should be unfractioned heparin, and warfarin is safe from 12 to 36 weeks. After that 36 weeks, again you go back to heparin because we don't want any undue bleeding to happen, which cannot be controlled. So if you have heparin, as I said earlier, it has a short half-life, and reversal also is possible. So first trimester and last trimester, you go for heparin. In between, you can use warfarin like your regular dosage. And this is the contract score, which is, identifies the risk with so many factors like prior cardiac event, functional class, reduced systemic ventricular function, left heart obstruction. Then the risk score is 0, means the risk is only 5%. 1 factor to 27%. When it goes to 2 factors, it will jump to 75%. Okay? And in case of vaginal delivery, good labor analgesia is a must, so that the uterine contraction does not cause a strain on the heart or cause a tachycardia and lead on to back pressure effect and pulmonary hypertension. And this is the obstetric management that you can do with the neuraxial methods of surgical delivery: epidural, spinal, combined spinal epidural, or general anesthesia. These are the 3 choices that you have to remember for operative delivery. Okay. Some general points to remember during pregnancy are: first trimester, avoid GAs, since organogenesis can be affected by polypharmacy. If needed, any intervention or surgery is needed, regional anesthesia is safe during the first trimester. Second trimester, safe period for any incidental surgery, and both and GA can be administered to any pregnant patient, but 4H you have to avoid are hypotension, hypoxia, hypovolemia, and hypothermia. And preterm labor is another risk during second stem surgery, and so tocolytics must be used if such risk is anticipated. And the third trimester surgery decision can be separate or combined with only about performing cesarean section first and then going in for can be done after pressure. Surgery at less than 36 administering dexamethasone to the mother. All drugs used must be safe for both mother and fetus. Aspiration risk, difficult airway, desaturation events be kept in mind while dealing with parceria at odd hours with inadequate health in the body. So many complications of airway morbidity and mortality have happened when you are called for an emergency cesarean section at the middle of the night at 1 a.m. or 2 a.m. When most of the staff in the hospital are sleepy and you don't get adequate help and you land up with a difficult airway, that is the time these complications happen. So that is the reason why I have put this particular point. And postpartum period is also equally important till 72 hours after delivery, because anything can go wrong up to this particular time. So these are the points that you have to remember. Take care. Okay.
Yes, sir.
Right. Any doubts or any questions on that?
No, sir. No, sir.
Right. If you don't have any questions, go on to the next topic.